Hi students, welcome back to my channel. Today I am going to discuss a very important topic in the field of dentistry, that is final impressions and creating the master cast. I hope you have all liked the previous video, that is fabrication of custom tray. After that step we will move on to the final impression procedure. So let's begin. Making the secondary impression is an important clinical procedure in the fabrication of complete denture. It is mainly done to prepare a master cast. And this procedure involves three steps: border molding or peripheral tracing, master or wash impression making, and post damming. Out of which the master impression is one of the most important steps in the fabrication of complete denture. It should record the denture bearing area at rest to reproduce various final details and also record the muscular peripheral tissues in function. There are two major techniques which are commonly used for the recording of the master impression of an edentulous arch, and they are custom tray impression and using tray compound. The custom tray impression is the most commonly used technique, and the custom tray is designed with a spacer which is adapted over the arch, and the tray should be 2 mm short of the sulcus, and the border molding should be carried out to record the sulcus in dynamic function. And the spacer is scraped off before making the impression, and the area where the relief wax is present, the pressureless impression is recorded. And where there was no relief wax, then the tissues are recorded under pressure. And this concept of applying pressure on certain area and relieving the others is called as selective pressure impression making. And using tray compound, primary impression is made. And this impression is refined and trimmed to avoid overextension. And a metal wire is attached to it to act as a handle. Now the tray compound acts as the custom tray. Border molding and wash impressions are made over this set primary impression. Actually, we have all learned this in detail in the previous lecture. You can watch that video. Then making a secondary impression using a special tray or custom tray. It is the most commonly used method for making the master impression. And this technique varies for both maxilla and mandible. But for both the impressions, the custom tray is fabricated with a spacer as described in the previous video. So coming to the final impressions, what is its definition? Actually, this is the impression which represents the completion of registration of the surface or object. And these are made using various methods. First one is the custom tray, then stock tray, then record bases with occlusal drums. So whatever method is used, all denture wearers are instructed to remove their dentures for 24 hours, that is 1 day prior to making the final impressions. What is its purpose? It is to enable the distorted tissues to return to the normal state. So the denture wearers, that is all denture wearers, are instructed to remove their dentures for 1 day, that is 24 hours prior to the final impression making. That is very important because it enables the distorted tissues to return to the normal state. So coming to the border molding, it's also termed as peripheral tracing. And what are its definitions? It have two definitions. First one is that the shaping of the border areas of an impression material by functional or manual manipulation of the soft tissue adjacent to the borders to duplicate the contour and size of the vestibule. And the second definition is that it determines the extension of a prosthesis by using tissue function or manual manipulation of the tissues to shape the border areas of an impression material. So border molding we will discuss in detail in my lecture. Okay. And the main purpose of this border molding is to create a peripheral seal. So it's also known as peripheral tracing. Okay. And it can be performed using two techniques. First one is the single step or simultaneous border molding, and second one is the incremental or sectional border molding. In both the cases, anterior portion is border molded before the posterior portion. Labial and buccal flange of the tray is border molded first, followed by the lingual flange. Okay. Here is the border molding sequence. This is for the maxillary tray border molding and this is for the mandibular tray border molding. For maxillary, labial vestibule is refined first, followed by the buccal vestibule and then the posterior parietal seal. For the mandibular, labial vestibule, buccal vestibule and then lingual vestibule. After border molding, the molded section is immersed in cold water. And after border molding a particular section, the procedure is carried out for the next adjacent section. So what about the single step border molding? It is actually using polyether impression material or putty material or a heavy body material. Okay. It is a procedure where the entire periphery of the tray is refined in a single step. So there is only single step. So it is known as single step border molding. Ideal material of choice is that the polyether impression material. So it fulfills all the requisites. So what are the ideal requisites for the material used for the simultaneous or single step border molding? It should have sufficient viscosity to remain in position along the borders of the tray. So it should have sufficient viscosity and it should not be sticky. It should be easy to manipulate and load on deficient areas. And it should have a setting time of 3 to 5 minutes. It should not displace the tissues and it should be easily trimmed and shaped. It should retain its flow properties when placed inside the mouth. So it should have sufficient viscosity. It is very, very important to remain in position along the borders of the tray. Okay. And it should not be sticky. So these are the ideal requisites of a material used for a single step border mold. Then coming to the incremental or sectional border molding. It's actually using with low fusing compound. This is a procedure where the portions of the periphery of the tray are refined individually. Here the material of choice for this procedure is green stick compound. And in this case, the spacer is generally removed just before the impression making. There are mainly two methods for manipulating the peripheral tissues. And they are active method and passive method. What is active method? Here the patient performs various functions related to the concerned areas to manipulate the borders. And passive method is that the dentist physically manipulates the tissues to mold them. That is active and passive. Okay. Here this is the maxillary diagnostic cast with the tray outline is marked. Now notice that here this is the high frenulum attachment and also tissue attachment. So the outline indicating the border of the tray is several millimeters above the depth of the vestibule in the anterior area. Okay. Noted the high frenal attachment. Here this is the custom tray which is fabricated with the labial and buccal borders of the tray. Here it is approximately 2 mm above the depth of the vestibule. Posterior extent of the tray is the vibrating line. Coming to the method of adapting green stick compound. Appropriate length of the stick corresponding to the length of the section to be molded is softened over a flame till it begins to droop. Here, the green stick compound is softened over the flame and added along the portion of the tray where the border is intended to be refined. And the material should be tempered with warm water before placing intraorally. Here, the compound is placed on the border of the custom tray, rotated slightly and then quickly pulled away to prevent the long strings from forming. So for remember, soften, then place, then temper, then form, then insert, then mold, remove, chill and trim. So for the maxilla, the secondary impression procedure includes border molding, tray preparation after border molding, making the wash impression, recording of the posterior parietal seal and checking for errors in the posterior parietal seal. Coming to the maxillary tray border molding, this is the sequence of border molding, that is labial flange, buccal flange, distal buccal flange and then posterior. Then the labial flange, with passive movement, that is lips are elevated and then extended outwards, downwards and inwards, ODI. Okay. Then active, the patient is asked to pucker the lips and suck on the dentist's finger. Then buccal flange, that is buccal frenum area. Here, it may be performed unilaterally. Passive, the cheek is elevated and pulled up outward, downward, inward and moved backward and forward. And active, the patient is asked to pucker the lips and smile. Then distal buccal area, it should be performed bilaterally. Passive, that is cheek is pulled outward, downward and inward. What is active movement? Patient is asked to open the mouth wide, close and move the mandible from side to side. So side to side movements. Then opening the mouth wide, which delineates the depth and width of the distal buccal flange. And while moving the mandible from side to side, it accommodates for the movement of the coronoid process. When the mandible is wide open, the coronoid process will come in close approximation to the distal portion of maxillary buccal sulcus. Here this is the condylar process and this is the coronoid process. So here when the mandible is wide open, this process come in close approximation to the distal portion of maxillary buccal sulcus. In this region, there is a thick denture flange. It can produce the interference in the movement of mandible and cause severe pain in that area. This movement of coronoid process is recorded in the impression and will become the coronoid groove in the finished denture flange. This is the coronoid groove. Okay. And the posterior palatal seal area is recorded. The patient is asked to say ah in short bursts to record this area. So this is the custom tray with posterior seal area molded. Coming to the secondary impression procedure for the mandible, it includes border molding, tray preparation and making the wash or master impression. Then coming to the mandibular tray border molding, this can be accomplished by the following using the following sections and sequence. This is the sequence of border molding in mandible, that is labial flange, buccal flange, distal buccal area including the mesotelic notches, then anterior lingual flange, middle lingual flange and posterior or distal lingual flange. Labial flange, passive movement is the lip is slightly lifted outward, upward and inward. Here one difference is that it is upward movement. Okay, so outward, upward and inward. Buccal flange in the buccal frenum area, it can be developed unilaterally. Passive, the cheek is lifted outward, upward and inward and moved backward and forwards. And active, by patient is asked to pucker and smile. Buccal flange area, distal buccal area, it developed bilaterally. Here the cheek is pulled buccally to ensure that it is not caught in the tray and moved upward and inward. Active and passive, that is, masseteric notch is recorded by asking the patient to close while dentist exerts a downward pressure on the tray. And to record the action of the masseter muscle, the patient is asked to willfully close his mouth against the resistance. Here this is the masseteric notch, and this notch is the masseter muscle which acting on the buccinator produces a depression in the impression. So what is masseteric notch? Actually it is the bony notch located on the inferior border of the mandible and the anterior to the attachment of the masseter muscle. So this is the masseteric notch. Here this is the masseteric notch. Okay. Then coming to the lingual flange. This is the anterior lingual flange. This is the middle portion of the lingual flange. So anterior lingual flange is recorded by active movement, that is the patient is asked to protrude the tongue and then push the tongue against the anterior part of the palate. And this develops the length and thickness of the flange in this area. So length is determined by when patient protrude the tongue, and the thickness of the flange is determined by when the patient push the tongue against the anterior part of the palate. This is the middle portion of the lingual flange. This developed bilaterally. Here the patient is asked to protrude the tongue and lick the upper lip from side to side. Then the distal lingual flange, it developed bilaterally. Active movement is that the patient is asked to protrude the tongue and then place the tongue in the distal part of the palate in right and left buccal vestibules. Okay. And the patient is asked to raise the tongue and touch the upper lip while recording the lingual sulcus. And the protrusion of the tongue helps to record the movement of the mylohyoid muscle. And this also raises the floor of the mouth. Increase in the thickness of the posterior part of lingual flange due to accumulation of border molding material can interfere with the action of the mylohyoid muscle. So the verification is by actually asking the patient to open mouth wide. If there is any notch in that area, it indicates the overextension or any interference from the pterygomandibular raphe, and it should be adjusted. And the patient is asked to wipe the tongue against the vermilion border of the upper lip. This should not displace the tray. And next is the single step border molding. In this method, entire periphery of the tray is refined in a single step. This is very, very important. So it is known as single step border molding. And the material is placed around the entire border in a single step and molded similar to the sectional technique all at once. Putty material or heavy body impression materials are ideal for this method, and green stick compound is not recommended because it is impossible to soften the material over the entire length of the border. So that is about the single step border molding. And the steps involved in the single step border molding. Here this is the putty additional silicone which is kneaded and rolled into a rope of required length. Here this is an adhesive which is applied on the outer surfaces and the inner borders of the tray. And the placement of the putty material which is placed around the borders. Here polyether material, it is syringed along the borders of the tray. For polyether impression material, it is mixed using less amount of catalyst to increase the working time. Then the mix is then loaded in the syringe and then the material is syringed along the borders of the tray and contoured using wet fingers. Alternately, heavy body impression material can also be used. It is syringed around the borders of the mandibular tray using auto mix syringe. And this is the picture showing after border molding. And what are the advantages of this technique? Number of insertions of tray in the mouth is reduced to 1. That is very important, and that is very important advantage. Error in one section will not propagate the mistakes to other segments. And what are the advantages of using elastomeric impression materials? Procedure is somewhat simpler and no need to temper and chill. There is less armamentarium required, no water bath and flames, and no fear of patient discomfort from heated stick compound. And what are the disadvantages? They will not adhere to the tray and require tray adhesive. So tray adhesive is required for the single step border molding. And they need good support from the tray, not indicated with grossly underextended trays. And the material is somewhat more expensive too. Okay. Here this is the posterior part of the palate is recorded and the patient is asked to say ah while refining the posterior border. After the border molding, polyether impression material sets and tray is removed. Borders are examined for deficiencies and overextensions and the master impression is made. And this is the completed maxillary final impression showing minimal pressure areas and the voids. Here the impression tray was cut back by 2 mm from the depth of the vestibule on the cast, but the borders of the tray are impinging on the movable tissues intraorally. So it must be shortened. And the buccal and labial flanges of this tray have been shortened sufficiently to create adequate space for the border molding material. Here the vibrated line has been identified at the midline and is marked with the indelible marker. Here this is the posterior end of the impression tray is shortened to coincide with the vibrating line. Here the fatty roll of tissue in the masseter muscle must be removed from beneath the impression tray when evaluating the extension of the tray. And there should not exhibit any sharp corners in the tissues in this area. And for most of the patients, labial and buccal, lingual flange will be of equal length unless any surgical extension of the vestibular notch or severe bone loss resulting in the genial tubercle being elevated. And the impression tray should show a smooth continuous decrease in the flange length as it continues from the buccal shelf area to the crest of the ridge. Here also there should be no sharp corners in the area intraoral. And the border should continue as a smooth continuous line from the masseter muscle area to the retromolar pad. And the lingual flange of the tray should resemble the smooth continuous line beginning at the level of the labial flange in the anterior and gradually increasing in length as compared to the buccal flange as it approaches and enters the retromylohyoid area. Only should be sufficient border modeling material is added to the tray to slightly overfill the space created when the tray was shortened 2 mm from the depth of the vestibule. Therefore, only approximately 3 mm of material is required to complete fill of the vestibule. If there is excess material, then it will overextend the flange length. Okay. So sufficient material is added to the tray. While the material is still softened, the border molding movements are completed. When removing from mouth, impression tray shows through the border molding material and the tray was insufficiently reduced. So any border molding material should be removed. Tray further reduced than border molding procedure is repeated. Here the border molding is completed and excess material has been removed. So material should be no more than 2 to 3 mm height above the tray flange. And there should be no areas in the impression tray as shown through the material. Okay. What are the reasons for errors in the impression? It is actually a common occurrence in the clinical practice, and most common reason is that improper positioning of the impression tray. If the tray placement is improper, the flange of the impression which lies on the side of deviation will be excessively thick and flange of the impression opposite to the deviation will be thin. And other reasons are large voids, improper consistency of the impression material, movement of the tray during the setting of the impression material, inadequate scraping of the border molding material, and the quantity of the impression material, that is using too much or too little impression material is used. And these are the reasons for remaking the impressions: incorrect tray position in the mouth, pressure areas in the secondary stress bearing areas, any void or discrepancy too large to accurately correct, incorrect border formation as a result of incorrect border length of the tray, incorrect consistency of the final impression material when the tray was positioned in the mouth, and distortion of the impression material because of movement of the tray during setting of the final impression material. And that is about the today's lecture. Stay tuned for part 2 of final impressions and creating the mastercast. And please do like, share and subscribe my channel for more dentistry related videos. Thank you.